Imagine breaking into a bank vault in the dead of night.
Okay.
You bypass all the sophisticated alarms, you crack the massive combination safe.
Doing all the hard work.
Exactly. And the heavy metal door swings open. Millions of dollars are stacked floor to ceiling. And then you just sit down on the cold concrete floor.
Just sit there.
Yeah, you leave all the cash right there on the shelves. You take absolutely nothing. You just sit there in the dark simply because, well, you're desperately lonely and the vault feels secure.
It's such a wild image, but it really captures it.
It really does. Today, we're exploring a deeply misunderstood psychological condition that does exactly this. But, the bank vault is a hospital, and the security guards are actually doctors and nurses.
Yeah, it's a completely different setting for that same behavior.
So, welcome to today's deep dive. We're taking a stack of resources, primarily leaning on a really fascinating clinical brief from a practice called Coping and Healing Counseling, or CHC. And, okay, let's unpack this, because we are going to completely reframe how you view what it means when someone is accused of, faking an illness.
Oh, absolutely. We're looking at factitious disorder today, and the chasm between public perception of this disorder and the clinical reality is, it's staggering.
It's massive, right?
Totally. When society hears that someone has falsified a medical condition, the immediate instinct is just to assume malice.
Right, like they're trying to pull a fast one.
Exactly. We operate on this fundamental social contract of truth, especially when it comes to, vulnerability and health. So when someone breaks that contract, we just assume they're running a con. We assume greed.
We assume they want to pay out.
Right. But to understand factitious disorder, we first have to isolate it from the behavior people are actually thinking of, which is malingering.
Yeah, and let's draw that line right now, because it is this foundation of everything we're going to talk about today. Think of malingering like a traditional heist.
Okay, I like that.
Let's say you fake a severe back injury on the warehouse floor. You memorize the symptoms of a herniated disc, you limp into the supervisor's office, and you play the part.
Right, you're putting on a show.
Exactly.
Yeah.
And why? Because you want 6 months of paid workers' comp. Or maybe you're angling for a massive insurance payout. Maybe you're dodging a court date or avoiding military deployment.
There's a clear goal.
Right. There's a calculated transactional motive. The quote-unquote illness is basically a crowbar you use to pry open a tangible, real-world reward.
What's fascinating here is that the clinical definition of malingering hinges entirely on that external incentive.
So it's all about the payoff.
Yeah, totally. The behavior stops the absolute moment the payout is secured. Or, the moment the risk of getting caught outweighs the financial gain. The individual is in complete control of the deception for material benefit.
But factitious disorder, it abandons that logic entirely.
Completely.
The individual falsifies or exaggerates, or even actively induces physical or psychological symptoms without any external reward whatsoever.
Nothing to gain materially.
Right. Going back to our bank vault analogy, they're sneaking into the hospital, navigating the triage nurses, getting admitted to a bed, and taking no money.
Wow.
There's no lawsuit. There's no paid time off. In fact, in many cases, their lives are actively ruined by the behavior.
Yeah, it's incredibly destructive.
They lose their jobs. They drain their savings, paying for, endless copays. They completely alienate their families. Just imagine how confusing that must be from the outside. Seeing someone fake an illness when there's absolutely nothing obvious to gain from it.
Which forces us to really look at the mechanics of the deception itself, because, it is far more extreme than just complaining of a headache.
Oh, absolutely.
The source material highlights that individuals with factitious disorder will go to terrifying lengths to manifest symptoms. We're talking about swallowing objects to cause internal blockages.
Wait, literally swallowing objects?
Yes, or intentionally contaminating urine samples with blood, or secretly injecting themselves with insulin to deliberately crash their blood sugar to dangerous levels.
That is just wow.
Right. They are actively putting their biological survival at risk.
Okay, I am struggling with this. Let's pause and really look at that, because this is where my empathy honestly hits a wall. And I imagine you listening might feel the exact same way.
It's hard to wrap your head around.
It is. If a patient is actively injecting themselves with something to cause an infection, that requires immense premeditation.
True.
They had to acquire the syringe. They had to plan the moment. So what does this all mean? How can a clinician look at that highly calculated deception, that deep betrayal of the medical system, and treat it with empathy instead of just seeing it as a malicious lie?
Well, the deception is undeniable, right? But we have to shift our focus to the psychological function of the lie. The behavior is premeditated, yes, but it's driven by a profound, completely unmet psychological need.
So it's not about the illness itself.
Exactly. The source material points out that the roots of factitious disorder almost always trace back to severe trauma, neglect, or just profound chronic loneliness.
Oh, wow.
Imagine, a childhood where the only time an overworked or emotionally absent parent paid attention to you was when you had a fever.
Okay, I see where this is going.
Right, like the only time the house was quiet, the only time you felt a gentle hand on your forehead was when you were physically broken.
So it essentially creates a Pavlovian response.
Yes,
Yeah.
it creates a deeply ingrained survival mechanism. The brain wires a sterile clinical environment, like a hospital or a doctor's office, as the ultimate source of warmth and safety.
That is so tragic.
It really is. The currency they're stealing isn't cash or time off work. The currency is the 15 minutes of unbroken eye contact from a sympathetic nurse.
Just to feel seen.
Exactly. It's the feeling of being the center of a team of specialists who are fiercely dedicated to keeping them alive. Because they rarely reach out for help on their own, given the immense shame and secrecy involved, meeting them with patience instead of judgment is just critical. The illness is simply a manufactured container for an emotional agony. They just don't have the vocabulary or the psychological safety to express otherwise.
So the hospital bed really is the vault. They are literally enduring physical pain just to sit in the vault.
That's exactly it.
Well, let's walk through what this actually looks like in practice. Because, this isn't happening in a cozy therapist's office. This pathology is playing out in busy emergency rooms and diagnostic labs.
Right, in real medical settings.
The CHC brief outlines specific red flags. And instead of just listing them off, let's imagine the journey of a hypothetical patient navigating this maze.
Okay, yeah, because the presentation is often quite distinct once you step back and look at the macro picture of the patient's life.
Right, so imagine a patient who walks into a new clinic in a new city. The very first indicator is just the sheer volume of their medical history.
It's usually massive.
Yeah, we are not talking about someone who gets the flu every winter.
Mm-hmm.
We are talking about literal binders full of medical records. They've bounced from endocrinologists to neurologists, crossing state lines, carrying this labyrinth of past diagnoses that don't quite fit together chronologically or even biologically.
And that geographic bouncing is a direct result of the disorder's life cycle.
How so?
Well, a hospital can only provide care for so long before they either cure the ailment or, the doctors begin to suspect the symptoms are self-induced.
And once they get suspicious.
Right. When the suspicion arises, the patient's fear exposure kicks in, they get terrified, and they flee to an entirely new healthcare system to just start the cycle all over again.
Wow. And then we see the second phase of this journey, which is this mysterious finish line flare-up.
Oh, this happens so often.
Let's say this patient is admitted. The doctors treat the infection, the antibiotics work beautifully. The attending physician comes in on a Tuesday morning and says, "Great news, your white blood cell count is normal. We're typing up your discharge papers for this afternoon."
And you'd think they'd be happy.
Right.
Yeah.
But instead of feeling relief, the patient feels a massive surge of panic. Because discharge means the attention stops.
The care stops.
Exactly. The nurses go away, the isolation returns. So inexplicably, by Tuesday evening, a brand new, completely unrelated symptom spikes. Suddenly they have severe abdominal pain or a sudden fever.
Because the disorder views a clean bill of health as an existential threat.
It's terrifying to them.
It is. The new symptom is basically a desperate anchor thrown out to keep the patient tethered to the hospital bed.
Which pulls us into the darkest, most jarring part of this journey. The patient's willingness to endure the consequences of that anchor.
This is the hardest part to understand.
Yeah. The doctors, baffled by the new symptom, they order more tests. And we are talking about highly invasive, deeply uncomfortable procedures. Most of us will do anything to avoid a lumbar puncture or an exploratory surgery or like another round of heavy radiation. We try to negotiate with our doctors to find the least invasive option.
If we connect this to the bigger picture, a person suffering from factitious disorder often eagerly anticipates those procedures.
They actually want them.
Yes, they will volunteer for exploratory surgeries. They will consent to painful biopsies. The tragic irony of this condition is just staring us right in the face. A human being is willingly submitting themselves to a cold, clinical, physically traumatic medical environment, allowing themselves to be cut open just to fulfill a starving emotional need to be seen.
It's devastating.
It is. The physical suffering is the toll they are absolutely willing to pay for the illusion of being cared for.
And here's where it gets really interesting. Because the very system meant to heal people becomes the unwitting stage for the disorder.
Unintentionally enabling it.
Right. The doctors and nurses are basically cast as actors in a play they don't even know they're in.
Mm.
And because medical professionals are trained, both legally and ethically, to take a patient's reported symptoms at face value and exhaust every physical possibility, they are trapped.
They have to follow protocol.
Exactly.
Hmm.
They were looking through a microscope for a virus or running an MRI looking for a tumor when the actual pathology is an invisible childhood trauma.
And it creates an endlessly destructive loop. The healthcare system exhausts immense resources running unnecessary tests, but more importantly, the patient is undergoing severe accumulating physical risks.
The toll on the body has to be huge.
It's massive. The risks of repeated general anesthesia, the risks of hospital-acquired infections, the scarring from multiple surgeries, and all of it is like pouring water into a bucket with a hole in the bottom.
It's never enough.
No. The physical care never fills the emotional void.
So, because the doctors are trapped treating the physical symptoms, the actual intervention has to happen completely outside the medical exam room.
Yes, it has to be psychological.
But if the core barrier to treatment is the sheer terror of walking into a psychiatric clinic and admitting to this elaborate deception, how do we fix that? Like, how do we break the cycle without triggering the shame that causes the patient to just flee again?
That's the real challenge.
This is where the framework from Coping and Healing Counseling CHC provides such a fascinating blueprint for accessible care.
Yeah, the clinical intervention required is psychotherapy. A skilled, licensed clinician has to gently peel back the layers of the physical symptoms to address the distress driving the behavior. But, as you said, if the patient is too terrified of judgment to even enter the room, the therapy cannot happen.
It'll just avoid it entirely.
Exactly. So the delivery mechanism for the care is honestly just as important as the therapy itself. There should be no accusations here, just compassion and support.
Which is why the structure of a practice like CHC feels basically engineered to dismantle the defenses of something like Factitious Disorder. Let's look at how they've set this up.
Let's do it.
First off, their practice is 100% telehealth and fully HIPAA compliant.
That's huge.
It is. For someone drowning in the shame of falsifying illnesses, the waiting room is a gauntlet. The drive to the clinic is just a chance to turn around. By moving the therapy entirely to telehealth, you completely remove the physical exposure. The patient can begin the process of unburdening themselves from the absolute privacy and safety of their own living room.
And it completely removes geographic isolation as well. Specialized psychological care is heavily concentrated in major urban centers.
So true. If you're out in the country, it's tough.
Right. If a patient lives in a rural area, the disorder uses that distance as a convenient excuse to avoid treatment. But the CHC model serves all 159 counties in Georgia. They effectively place a licensed clinician in every single living room in the state.
And it is a robust network. We aren't talking about a single practitioner spread way too thin. They have over 15 licensed therapists.
That's a solid team.
Yeah, that includes licensed clinical social workers, licensed professional counselors, and licensed marriage and family therapists. The brief specifically points out that the team is diverse and culturally competent. They offer everything from individual and teen therapy for ages 13 and up to couples counseling, family therapy, and even life coaching.
And the modalities they focus on are exactly what is required to treat those hidden drivers we discussed earlier.
Definitely. Their core specialties read like a direct map of the underlying causes of factitious disorder. They cover trauma and PTSD, anxiety, depression, grief, relationship conflicts, and severe stress.
They're treating the source.
They are equipped to treat the root of the tree rather than just pruning the branches.
Yeah.
But here's the piece that I think is the ultimate circuit breaker. We established early on that people with factitious disorder are not doing this for financial gain, right?
Right. There's no payout.
In fact, the hospital bills, the travel, the lost jobs, it often leaves them in absolute financial ruin. So the cost of therapy is a massive, incredibly real barrier.
Financial fiction is one of the most common reasons individuals abandon mental health treatment, regardless of what the diagnosis is.
Exactly. And CHC has structured their practice to neutralize that friction. They accept Medicaid with a $0 copay. $0.
That's incredible.
It really is. And for major insurance networks, they accept Aetna, Cigna, Blue Cross Blue Shield, United Healthcare, and Humana. The out-of-pocket cost ranges from just $10 to $40 a session. They have essentially removed the "I can't afford it" excuse that the disorder uses to protect itself?
This raises an important question, though. When you combine the $0 Medicaid copay with a low-barrier, in-home telehealth model, you change the entire equation for the patient.
You really do.
You are offering a quiet, completely safe off-ramp from the terrifying medical maze they have trapped themselves inside.
Yeah.
There are no dramatic confrontations required, just easily accessible, compassionate support.
And if you're listening to this and recognizing these patterns in yourself, or maybe you're watching a loved one navigate a suspicious, endless cycle of medical crises, this kind of frictionless care is actually available.
It's out there.
You can reach the team at CHD by calling 404-832-0102. You can explore their therapists and their approach at cheattherapy.com, or simply reach out via email at support@cheatagedtherapy.com. The infrastructure for healing is there, and it is accessible.
And the transition from a cycle of deception to a path of authentic healing requires a profound shift in perspective, not just for the patient, but for the people around them.
Yeah, to bring all of this together, we have completely redefined a condition that society often just dismisses with a cruel label. Factitious disorder is not a manipulative cry for attention in the way we traditionally use that phrase.
No, not at all.
It is a highly complex, deeply painful response to isolation. We've traced the pathology from the childhood trauma that wires the brain to seek comfort in sterile hospitals, through the red flags of bouncing between clinics and enduring unnecessary surgeries, and finally to the ultimate solution, removing the barriers to psychological care through models like CHC.
Before we wrap up, I want to leave you with a thought that really builds on everything we've unpacked today.
I'd love to hear it.
Consider the sheer magnitude of the biological drive we've been discussing. If a human being is willing to endure unnecessary, physically agonizing medical procedures, if they're willing to be cut open to risk infection, to isolate themselves from the outside world entirely, solely to secure a fleeting moment of warmth and care from a stranger in a lab coat.
Just a few minutes of attention.
Right. What does that reveal to you about the sheer, undeniable biological necessity of human connection? It tells us that, to the human psyche, being entirely unseen and unloved is actually more painful and more terrifying than profound physical suffering.
Wow. The pain of being unseen is greater than the pain of the scalpel. That is an incredibly heavy, illuminating realization. Thank you for joining us on this deep dive. We hope you walk away with a completely new lens through which to view human behavior.
Absolutely.
We encourage you to approach the world with a little more curiosity and, a lot less instinctual judgment. Because sometimes the person sitting alone in the dark bank vault doesn't need to be arrested. They just need someone to sit down next to them and ask why they feel safer in the dark.
Take care of yourselves, keep asking the big questions, and we will catch you on the next deep dive.